Fellow here at the Austin Hospital, and as he put it, a newly minted haematologist. So congratulations to Joel for being a new consultant. Joel is going to talk to us today about the latest information on lymphoma and current treatments. Thank you, Joel.
All right. Good afternoon, everyone. I see some very familiar faces in the crowd, so it's nice to see some of patients and family members. So thanks for coming along. I just want to start off by saying this is a very informal thing. Doctors speak gobbledygook all the time, and if I say something that you don't understand, please put up your hand and say, what does that mean? Okay? I want to make sure that we're all on the same page, all right? So I'm going to try and get rid of that jargon, and I'm going to try and pitch it at a level that everybody here understands. Okay? So please interrupt me. What is lymphoma? Now, most of you have had at least some experience with lymphoma, either personally or through a family member. I can tell you that there are a lot of different kinds. The sort of saying I have lymphoma is kind of like saying I own a car. All right? Owning a car can be, or a vehicle can be a very different experience. You could have a smart car, or that's a Bugatti Chiron, I think, the most expensive car in the world at the moment. Production car, or a combi van, or a Mack truck. And lymphoma is kind of the same. There are many different forms. There are aggressive forms, there are indolent forms, and we kind of decide what the lymphoma is based upon a whole number of different characteristics. This is the most recent, in fact there's been one more update since this time, but this is basically how many lymphomas that there are. All right. So as you can see, there's quite a lot there, and this is why it's sort of its own specialty field. There's about 50 different kinds. Okay. By far and away, the most common kinds are the ones that will be represented in this group. Most commonly, you'll have things like diffuse large B-cell lymphoma, which is the most common type of lymphoma. There are also others like small lymphocytic lymphoma, or CLL. Some people will have that. Other things like follicular lymphoma. These are really common types. But generally speaking, we kind of try and put lymphoma into silos, okay? So we can sort of figure it out and figure out how to treat it and what kind of medicines are going to work, what kind of things we should tell you about how it's likely to respond. Are we going to cure this, or are we just trying to control the disease? All those sorts of things. So the first thing we think about is, how does it behave? Is it indolent or is it aggressive? The classic kind of archetypal, I suppose, indolent lymphoma is something called follicular lymphoma. And follicular lymphoma, very often, if it's not causing you any problems, we'll just leave it alone. We don't touch it, we don't treat it. And many people, you can leave it alone for 10 years and it won't do anything. It just sits there and does nothing. Okay. The sort of classic archetypal aggressive lymphoma is something like diffuse large B-cell lymphoma. So you have to treat it now, because if you don't treat it now, then eventually it will kind of take over your body, and without treatment, then it's a fatal thing. And so we have to kind of get onto it right away. The second way we try and think about lymphoma is what kind of cell has gone bad, right? Like with any kind of cancer, we have an original cell that starts off bad. So it's like colon cancer, which is one of the cells from the inside of your colon, or breast cancer, which is a cell that comes from a breast tissue, or prostate cancer, which comes from the prostate gland. In the same way, lymphoma, they don't all come from one particular kind of cell. They come from, usually, and there are a few others, but generally speaking, they come from either a B cell or a T cell. The vast majority of them come from B cells, and these are all cells of your immune system. And these behave very differently, and the treatment for each condition is very different, because the cell that starts it off has different response to different kinds of treatment, and I'll talk a little bit about that in a moment. What does it look like under the microscope? So sometimes lymphomas will look very aggressive, sometimes they'll look very indolent, sometimes they'll have big cells, sometimes they'll have small cells. Sometimes the vast majority of the cells, and something like a classic example would be Hodgkin's lymphoma, sometimes all of the cells that are around it are actually inflammatory cells, and the tumour cells are very few and far between, which is very different to something like diffuse large B-cell lymphoma, where almost all of the the cells in the lymph node, tumour cells. And so we kind of use those ways to distinguish and to kind of, put it into different silos. And then sort of one of the things that you will all be familiar with is, where does the lymphoma like to live? Now, some of you will have presented because you had a lump pop up in your neck or under your arm or in your groin, and that's the classic, if you like, presentation of lymphoma. It comes up in lymph nodes, right? But there are actually lymph tissues in many, many places in your body. And sometimes lymphoma doesn't even have to occur in a lymph tissue. Sometimes it can occur in other places. So sometimes you'll find them mostly in the bone marrow, mostly in the blood. Sometimes it's in the liver or in the spleen or in the gut. There are lymphomas that present in the brain, for example. And so all of these different things, we put it all together. And then more and more recently, we're starting to figure out about the genetic problems. So what is the actual mutation or the problem that happened that actually made the lymphoma the lymphoma? Okay, all of us probably make cancer cells every day, and we need to figure out why it is that some of those, and by cancer cells I mean cells that develop mutations within their genetics. And normally what happens is one of two things happens. And those of you who are my patients would have heard me say this before. Your cells are supposed to have basically a kill switch, such that if they develop a mutation, so the genes inside the cell start to go rogue, they're not right, and the cell starts growing in a way that's uncontrolled. What is supposed to happen is those cells are supposed to undergo what we call apoptosis, which is basically programmed cell death. It means that the cells will commit suicide for the sake of the body. Okay, so they're supposed to do that, number one. Number two is, if they don't do that, you've got a backup mechanism, and that backup mechanism is your immune system. So your immune system is sort of scavenging around, not only fighting viruses and bacteria and other kinds of infections, but it's also looking for cancer cells. And then when it finds a cancer cell, it is supposed to go and kill that cancer cell. Okay? So in order for you to have lymphoma, or any kind of cancer for that matter, both of those things, the tumour cell has to find a way to escape both of those mechanisms. So it needs to no longer undergo apoptosis, programmed cell death. It must no longer listen to the signals for it to commit suicide. And it must also find a way to evade or escape the immune system, or your immune system must not be working very well. And in fact, we find that in patients who do have immune system problems, that they're more likely to develop most kinds of cancers, but in particular, they're likely to develop lymphoma. Okay? Any questions about that so far? Okay, clear as mud. Yeah?
It's probably inappropriate, but so for something like sarcoidosis, which is what I had, and could that mean that your immune, even though maybe it's not connected with lymphoma, if your immune system is down because of that, then you're more likely to be able to develop it because it's not doing the work?
Yeah, good question. Sarcoidosis is different, as you're right. It's not a lymphoma. It's actually kind of an autoimmune disease, and we don't really know very much about why it happens and what sort of kicks it off. It's unusual for sarcoidosis to kind of predispose lymphoma, if you like. When we talk about things being of increased risk, when I say it's increased, I mean that the risk of anyone getting lymphoma in society is about, the incidence of all kinds of lymphoma is probably about 15 to 20 per 100,000 per year. So that's not a very high amount. And so if I'm talking about your risk being increased, I'm not sort of saying that, it's like a coin flip whether or not you're going to get lymphoma. No, you're still very, very unlikely to get lymphoma. Yeah.
But it could increase.
It could do, but probably, sarcoidosis probably not so much. Usually the sort of treatment, if you have to be on really long-term, like immunosuppression drugs, for example, which sometimes people with sarcoidosis can come off. So, yeah.
Just a question about the immune system not working very well. I'm interested in that. I was tested for, HIV, Hep B and everything else when I was diagnosed.
Yep.
I had follicular lymphoma. And I'm pretty healthy and fit, and I exercise a lot, eat well and all of that. And so the obvious question is, why would one's immune system not be?
No, it's a good question. So it's either that the tumour has found a way to escape the immune system, so your immune system actually works perfectly well, but the tumour has found a way to kind of avoid it. So it's like taking the back streets to avoid the cops if you've had one too many drinks on at your Christmas party. So they can so it's not that the cops are doing a bad job. It's not that they're kind of sleeping on the job. It's that you kind of avoid them if you like. And so that's probably what most tumour cells do, is they find a way of avoiding the immune system. Follicular lymphoma is an interesting one because in fact, sometimes it happens very occasionally. It's not a common thing, but very occasionally what will happen is the immune system almost sort of seems to kick back in, and it just makes the lymphoma disappear all on its own without any treatment. Sometimes we see that happen. It's rare, but it does happen. It's what we call spontaneous remission. It just, the immune system just takes care of it and off it goes. So one of the ways that we're thinking about treating follicular lymphoma now and other kinds of lymphoma is basically just trying to wake up the immune system to either recognise that the cancer is in fact a cancer, and that's probably the most common thing. So it's not that your immune system is going to be you're going to be prone to infections and all that kind of stuff. More that the tumour has just found a way to hide, if you like. Yeah. So it's nothing wrong with your immune system per se. Yeah.
And is someone going to talk about those drugs?
I am. Yeah, a bit later. Yeah.
Fantastic.
Yeah. Okay. All right. So, thinking about lymphoma treatment, and this is probably an important slide for most people, is that there's kind of a trade-off, right? So, if you've got a really aggressive type of lymphoma, that we kind of, you'll see us all go into a spin, and we usually admit you to hospital and get biopsies and do scans and get started with chemotherapy usually within a couple of weeks of you presenting. Because you can be quite sick, and if we don't get it started quickly, then you could succumb to your disease. The most aggressive kind of lymphoma in the world that you can think of is a disease called Burkitt lymphoma. It's quite rare. And if you don't treat it, generally speaking, you've got about a week usually before someone's super, super sick, and then it gets really hard. But our cure rates for that disease are over 90%. So the disease is very, very sensitive to chemotherapy. Similarly, with diffuse large B-cell lymphoma, we cure more people than we don't. Okay, so we're reasonably good at treating a disease like diffuse large B-cell lymphoma. Okay.
Would you put Hodgkin's lymphoma under aggressive?
Hodgkin's is aggressive lymphoma. Yeah,
Thank
it is.
When you're talking about cure rates, you're talking about 5-year survival, 10-year survival, or what?
Well, that's a good question. So there's a difference between cure and remission. So when I say cure, what I mean is that the disease will never come back. It is gone forever. Now, the only way that we can be sure of that is that the disease never comes back. And so, if you live for 25 years and you're disease-free and it hasn't come back, are you cured? Almost certainly. And in fact, we tend to use a surrogate of about 5 years after a lymphoma of an aggressive lymphoma diagnosis to say that, you are almost certainly cured at 5 years. That said, I have met a handful of patients who have relapsed after 5 years with the same disease. And so obviously they weren't cured even though we thought they were. So remission just means that your disease has gone away to the point where we can no longer detect it, which says more about our tests than it does about your disease. Okay. So remission is a really good thing, but it doesn't necessarily mean cure. But when I say cure, I mean, what people really want to know is my disease ever going to come back? And the longer we go without your disease coming back, the more and more certain that we get that it won't come back. Okay, and that's particularly true of the aggressive type of lymphomas. Okay. Come back over to the other side, like I said, for something like follicular lymphoma, sometimes diseases like CLL. These are indolent diseases that very often they don't make you sick. Sometimes they'll present with a little lump somewhere, or sometimes actually you'll find them in an incidental way, right? So you have a scan for something else, and all of a sudden they find these lymph nodes. This happens, I see patients like this in clinic almost every week. Okay, they've had a scan for something else, and then all of a sudden they've got some lymph nodes there. And if you didn't do the scan, you'd probably never find it. And they might A, never ever need treatment, or B, they might go for a very long time before they ever need treatment. Okay. But when it comes to the point that if you do need treatment because it's causing you symptoms, then they're actually much harder to cure. They're usually sensitive to the therapy that we use, and sometimes they'll stay away for 5, 6, 7 years, sometimes longer, before they come back. But the general rule is that they usually do come back. Okay, but again, when they come back, very often they remain sensitive to being treated again. So kind of with lymphoma, generally speaking, and this is not the rule for everyone, but generally speaking, what you lose in sort of curability, you gain in kind of indolent sort of lower numbers of symptoms and kind of more indolent biology of the disease. So it tends to go on for a much longer time. Does that kind of make sense? Now, that is a general rule. Okay, there are some aggressive kinds of lymphomas that are really, really hard to cure, and there are some indolent lymphomas that we actually nowadays with modern therapy we actually probably can cure. Okay, but this is a general rule. Yeah. Okay.
No, sorry. Again.
Yeah.
What about an indolent that turns to aggressive?
Yeah, that's a good question, and that can certainly happen. It's indolent lymphomas that turn to aggressive lymphomas. It sort of depends on how long they've been going for, and it does tend to mean that often the disease behaves a bit more aggressively, and sometimes doesn't respond quite as well to our treatment that we can use. Sometimes what will happen is you'll have an aggressive transformation of an indolent disease. You can treat the aggressive transformation, that goes away, and then if you relapse again later, you can either relapse with the aggressive form or the indolent form, and so sometimes it sort of comes backwards and forwards and backwards and forwards, and I know there's some patients in the audience for whom that has happened.
So you're more likely, if it ever goes to aggressive, the aggressive in that situation can come back more than if you just had aggressive and treated in the first place?
Yes, probably. Yes, that's the. But again, more likely and less likely is relevant when you're looking at big populations. It's not really relevant for one individual person, because for you it's only relevant if it comes back or if it doesn't. Yeah. So what do we do for lymphoma? How do we treat it? There's lots of different kinds of treatment for lymphoma, but the vast majority of it really is a combination of chemotherapy and immunotherapy. Okay, most lymphoma will be treated in this way. We do have some additional therapies like radiation. Some of you will need that, and then there are some newer therapies called targeted therapies that kind of work by trying to block various proteins within the lymphoma, and some of you have been on those here. But chemotherapy, even though it sounds scary, is actually in lymphoma treatment is usually pretty well tolerated, unless you've got a very aggressive form of lymphoma and you need to be in hospital for your treatment. That can happen. But also, it tends to be really highly effective, and even though we're trying to find ways to, we're experimenting with all of these new and exciting therapies, some of which we'll talk about, the bottom line is that we service most lymphoma patients pretty well with standard chemotherapy. Okay, most people do pretty well with the kind of treatment that we've got, and the temptation is to think, oh gee, I don't want chemotherapy, I want this kind of new flash, exciting thing that I've heard about in the States and I've heard about on the news, and this, that, and the other. And in some cases that's appropriate, but in most cases, actually, our standard of care, chemotherapy, is really, really good. We'll wait for them to.
Medical emergency team towards 6 West stroke unit.
Okay. So, when I say chemoimmunotherapy, what do I mean? Well, the most common type of immunotherapy that most of you would have had is you've got a B-cell lymphoma, like diffuse large B-cell lymphoma, like follicular lymphoma, for example, is rituximab. Okay, so that's what we call an antibody. So it's like an antibody, just like your body would make antibodies to the flu, or like it would make an antibody to a bacteria. In the lab, they've created an antibody that targets B cells. Okay, which is pretty cool, and it's been around for we've had free access to it through the government for about 15 years now, and this drug has really revolutionised the way that we treat B-cell lymphomas. Okay, some indolent lymphomas, sometimes all you will use is rituximab, depending on various clinical circumstances. But usually we pair it with some chemotherapy. Okay. R-CHOP is sort of the most common type of chemotherapy that we would use, and those of you who have had diffuse large B-cell lymphoma, sometimes follicular lymphoma, what you will have had is R-CHOP, and that's just 4 different kinds of drugs plus rituximab. Okay, one of them is just a steroid, it's tablets that you take, and then the others are kind of intravenous chemotherapy drugs. Most of which are pretty well tolerated. They have some side effects, of course, as does every treatment, but most people get through it pretty well. RCVP is like R-CHOP light, if you like, so there's one less drug, otherwise it's all the same. Don't let the letters confuse you, because the V and the O are actually the same.